Okay, you guys have been awesome, and our patient's been great. Cynosure has been an amazing host. They let us talk about other things, other technologies, Botox, fillers, and that's important because you're not going to be successful just with an EBD, energy-based device. You need EBDs, skincare, you need injectables, you need an integrated approach to marketing. And so Cynosure's done a good job over the last decade helping a lot of practices grow. That's why 50% of all their sales are to existing customers, because you have a comfort level with them, and they generally, for a capital equipment company, do a pretty good job supporting. All companies are irritating. You have to find the least irritating of all the companies that you want to work with. And that has the technology you're looking for. Now, we're now going to progress. This was an artificial break. I would have done her smart lipo, and in fact, while that mesocaine and tumescent was working, I would have gone Botox brow lift, little filler, gone right down and done the submental neck work and be done. So this whole thing would take me about 30 minutes in my side office. And we'll talk about how to charge for up here, down there, or both. Okay, so let's do a Botox brow lift. We use some volume to support some deflated buttresses of the face. Buttress number 1 is a supraorbital temporal hollow. Buttress number 2, infraorbital. Buttress number 3, malar zygomatic. Buttress number 4, mandibular border, the entire mandible. So 4 buttresses on the right, 4 on the left. And you have to shape them, and everyone's different. You have to get the buttresses to lift and support without looking like filler face. Everyone that, if you just inject here, it's going to look crazy. Supraorbital, temporal, infraorbital, malar zygomatic, mandibular. 4 on this side, 4 on that side. You baked a cake. You put an icing on it. That's the lip. A little cherry. That's the nose. So I look at all buttresses. Not everyone needs everything, but I look at all buttresses. Yep or no. My average amount is about 8 syringes, because I have a pre-selected practice over a decade and a half where people come because I'll lift their face with injectables, and that's why they come. So I don't see 22-year-olds that want just a lip augment. I have 5 nurses that do that. I see older women that have had a facelift, want to sustain it, or want a non-surgical facelift, suture suspension, volume toxin, suture suspension, volume toxin, neck. Now, I would do a suture suspension lift here, except the company that has just had their PDOs approved in the US still needs to get a suture fixation component. Injectable PDOs are like doing sculpture. Okay, but they're not a true thread lift. Thread lift needs a suture to be sutured to the craniofacial skeleton and lift. And that's the one I'm going to start demonstrating these workshops when the company has their stuff together to distribute it properly. Okay, so let's take a look at this young lady. We can extend her well from her neck to her face. We had a little break for coffee, but we would have just kept on going. So the first thing we're going to do is chin down just a bit. Let's look at her face here. What would she benefit from? What do everyone always benefits from at this age? A little tail of the brow elevation without looking like Diablo. And so we want to get a little plumping and lifting of the tail of her brow. Lift your brows up, chin down, and look directly into the camera there. And so what I need to do here is lift up just a bit. You can't be back too much. You've got to be looking into the camera there. That's beautiful, actually. Lift your brows up and relax. Lift your brows up. Now, why can't she move? I froze her. And that's why I often will show you the Botox before, I do the freezing, because she can't move now. Now, when she was moving, we know what she wants. Everybody wants a little tail of the brow elevation. Get that heavy skin off the upper lid. Close your eye. No blepharoplasty scar. Look up, way, way, way up. You had a lower lid bleph scar, but no upper lid? Did you have your lids done way back when? Okay, so we're going to have a little elevation here. Now, how we're going to do that, we're going to knock off her central depressors. We're going to knock off her lateral depressors, so the elevator frontalis does that. And that's going to be with Botox and a little support in the tail of her brow using a filler. Same on this side, supraorbital buttress. Her temporal hollow's not so bad. I'll show you how you might inject it if you want to, but she doesn't really need it. So that's buttress number 1, supraorbital temporal. Buttress number 2, look up in the air. She's actually not so bad. I want to support the infraorbital buttress off in the tear trough and right across to the other side, especially right here, because as I build up her zygomatic malar eminence, you created an indentation. Same on the other side, down the tear trough, across the orbital rim to the other side, buttress number 2. Buttress number 3 for her is a little touch in her zygomatic malar sweep, not the malar eminence, and right down that orbital malar groove. So buttress number 1, buttress number 2, buttress number 3. Down the orbital malar groove, which is a nasojugular over the orbital rim, and a little bit of volume right there, and then upper zygomatic malar eminence to give her a little bit more oval look to her face. She doesn't have much in the way of a smile line. I rarely inject it, but she did have a little bit of a down-going mouth, the mouth pout, and we want to support that. And then I promised some people I would do a little lip augmentation. Hard for me to believe that those are natural lips, but you know, God works in mysterious ways, and it's a very mysterious upper lip. Her lower lip doesn't quite match the upper, so we're going to do a little lip augmentation, rolling the lateral lip segment out and having the lower balance the upper, so it looks a little more balanced, and get the corners of the mouth up. Okay? And so the last buttress I usually do is in front of the pre-jowl. There's the jowl, in front of the pre-jowl. And I'll put a tiny little bit in the post-jowl sulcus right here, or the mandibular border, to give the jawline lift and effect. So buttress number 1, buttress number 2, buttress number, let's do that again. Buttress number 1, buttress number 2, buttress number 3, buttress number 4, and then lip and nose. That's the icing and the cherry. So 1, 2, 3, 4. Create an oval face, and then a little bit in the central part of the face if needed. So first of all, I uncouple all the depressors from the elevators. Again, if you could not videotape this, this would be great because she's not supposed to be on your cell phone, okay? And you wouldn't want to be on her cell phone. So chin down just a little bit. She can't move much, but after I'd have the patient elevate, I'd have her smile, I'd have her squint, and she'd go, and there's her depressor corrugator supercilii. When she smiles, and she's pulling down her brow centrally and laterally. So we uncouple the depressors, her brow opens. Not a lot, couple millimeters. A little bit of filler helps. Little fraction of CO2 tightens the skin. Little thread left on the top anchors that. All the non-excisional techniques I use to reposition the face. Only thing you're not seeing today is the thread lift, but stay tuned because the next Sino workshop, probably suture suspension thread lifting, I will be part of this Sunday as well. Not PDO injectable threads, I'll show you those, but they're like doing sculpture. Okay, be angry. She can't move, so we'll pretend she's angry. Right now she's got frozen face because she's numb, she's ready for CO2. I take my Botox. Oh yes, I forgot about product support moment. Allergan, 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 Allergan as the co-sponsor of this morning. Thank you very much. Comes in 200, 150 unit vials, depends on the state you're in. Some states are single-use vial states. You can only use that vial on one patient, that's it. Those are the 50 unit states. The others are 100, 200 units. Generally, I mix up on my injection day on a Friday. All the Botox we're probably going to need, and we inject it all on that day. It will last 30 days in the fridge, so you don't need to use it that day. You have to keep it sterile. And so we mix. I'm a 2-to-1 or 1-to-1 guy. Most common 2-to-1, meaning 2 cc's of preservative saline for every unit. So rather than 2 cc's in a 200 unit vial, that would make you a 1-to-1 diluter. I put 4 cc's, so it's a 2-to-1. 1-to-1, 2-to-1, that's pretty concentrated, has the least dispersion of all. In Europe, you often see 4, 5, 6-to-1. Much more dilute Botox over there. And so we're much more of a concentrationist sort of continent. We don't like dispersion because you can get dribbling onto the levator and ptosis, so you can get dribbling onto the zygomaticus major, minor, and droopy smile. So keep it fairly concentrated. That's what most people do. So when we look at a 2-to-1 dilution, which is 200 unit vial and 4 cc's of preservative-free saline, that means this 31 gauge B&D needle, zoom in on this, is not 30 units. Zoom out so you see the whole, there we go. That is not 30 units, that would be if it's 1-to-1 dilution. This is 2-to-1, therefore that is 15 units. And so 30 to 20 ain't 10, it's 5. 20 to 10 ain't 10, it's 5. 10 to 0 ain't 10, it's 5. Why do I like that? 5, 5, 5, I use 5 units everywhere. And I don't have to squint and look. 30 to 20, 5 units, I can see it easily without glasses on. 20 down to 10, 10 down to 0, boom, 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 5 units everywhere. So often, look up here, I'll do 15 units in the depressor, 15 units in the depressor, 15 units, 15 units, 15 units. I use 15 units everywhere because I'm a pretty assertive injector. People who come to see me are quite depressing. Depressive, which can be depressing. And so I often use 10 units centrally when I'm doing laser. I don't want dispersion, so I take my 30 down to 20, there's 5. 20 down to 0, that's 5. There's 10 units total. I'm down at the hub of the needle. I'm in the sub-Q. I don't want to hit frontalis, which comes up to the dermis and inserts on the dermal margin of the brow. I want to be under the frontalis so I don't weaken it at the brow level. I want to lift. Now, what do I do with the other 5 units? I'll save it, or I put it here in the second depressor centrally, which is procerus. Procerus pulls down the central brow. Okay, a little heme, let's dab it. And so there's my 15 units. I take another 2-to-1 dilution, 15 unit toxin. You could use Dysport. Dysport in my hands is really 4-to-1, not 3-to-1. Xeomin is not 1-to-1, it's 1.5 or 2-to-1. There goes all the price differences out the window. You choose a pharmaceutical company for the points program because they're all about the same. I see no difference between Xeomin, Dysport, and Botox. I like Botox because I use Juvederm, Kybella, Zeltiq, Juvederm. I said that. I use a lot of Juvederm, so I said it twice. Cohesive Gel and Spira implants, Skin Medica. I use a lot of Allergan products, which puts me in the inner circle of awards points. It means I can get my Juvederm down to about $150 a syringe for Voluma versus the $400 they want to sell it to me for. I'll tell you how you can get it down to $200 instantly. Okay, so let's take this to the other side. I'm also a palmer. I inject with my palm. I use my 3 fingers to stabilize. I do that. And I use my ring finger to pull back to create negative pressure so you don't dribble all over their skin. Now, a lot of people like to do this. Some people like to do that. I don't care. However you like to do it, just don't dribble Botox in their skin. They're not paying you for transepidermal administration. Okay, so you want to catch the corrugator, which is central, and it does this. The lateral corrugator does that. I don't chase out much beyond the body. I never go after the tail because they can get ptosis, especially when there's edema and laser. So bring them back in a week or 2 and touch up all the little areas you don't do at the time of your primary everything at once. This is also the least safe way to do it. Do all your laser and filler together, bring them back for Botox in a week or 2. I can't afford to do that. That's 2 visits for the same patient, many out of town. They wouldn't tolerate that. Everything is done at once. Is that the best way to do it? No, but you can do it that way. Okay, toxin centrally, corrugator supercilii, right down to the hub to avoid frontalis, 30 down to 20, 20 down to 10, pull back, no dribble, voila. Now, if you notice, I use a glove where I touch the patient. I don't like a glove on my other hand because I like to feel what I'm doing. But this hand never touches the patient, never touches serum or blood, heme. Okay, let's save that little 5 units for somewhere else. Where else? Well, now we got to do the lateral depressive complex, which is the vertical fibers of orbicularis oculi, superior, middle, and inferior. Be careful of inferior because like the tail of the corrugator, you can get dispersion onto zygomaticus major and minor. And so I do the upper vertical fibers of orbicularis oculi. Here I do intradermal injections. Why? Because she's got a lot of veins there, and the number 1 risk here is ptosis there. The number 1 risk here is ecchymosis or bruising, so stay out of those veins. I come down to the lateral canthus. I'm 1 finger breadth away from the lateral canthus to avoid dispersion over the edge and a lateral rectus palsy and diplopia. So stay 1 finger breadth lateral, stretch the skin, look for veins, and you're doing like a TB test. Intradermal, 5 units, just like that. Now I could come around the corner and do the last vertical fiber, but I'm very close to zygomaticus, which does this. I don't want to get a smile weakness from dispersion, a lot of swelling when you're doing lasers. Don't do that 1 point. Come back. Okay, contralateral vertical depressor, we want to knock off this, so she does that. Knock off this, so she does that. Hit the vertical depressor, upper fibers orbicularis oculi, after which it becomes a secondary corrugator. You often get little lines when she can't frown. Watch out for compensatory recruitment of other muscles. When she can't frown here, she'll frown through her eye. When she can't squint here, she'll squint through her nose. So look for compensatory orbicularis oculi, horizontal fibers, and nasalis. And you have to add that maybe at year 1, year 2 of their injection program with you. Now stay intradermal, watch out for bruising. And now we come down to the lateral vertical fibers. Central, we stay 1 finger breadth from the lateral orbital rim, intradermal. And now we've injected 10, 20, 30, 40 units of Botox to knock off central depressors. Now, and lateral depressors, I want to get the nice elevation of her brow. She can't lift her brow, but I want all the frontotemporal branch innervation to go to the lateral half of her frontalis. So I'll soften the central frontalis to give this a little bit of a Diablo shape. Not like that, but just like that. Tilt the tail of the brow up a little bit. So I weaken with about 8 to 10 units of toxin intradermally in the horizontal lines. Not too much. just soften so the lateral frontalis gets most of the work. Again, intradermal, you don't want to bruise here, it lasts forever. And this is pain-free because I anesthetized her brow. So if you're going to do this without movement, make sure you know what movement she had and remember it. Because you can do Botox if they don't move, just remember where she moved, okay? Now that's a Botox brow lift. I'm not done yet. If she's a nasalis kind of gal, I'll put 2 units from the nasofrontal groove right up to the sidewall of the nose. Watch out for the angular vein right here. You can get a bruise, so stay on the nasal sidewall. 1 to 2 units right there. Little pinprick. 1 to 2 units right here, so she doesn't have this accessory crunching. Look way up in the air. She's got some crinkles there. If she has good laxity, good tone of her lower lid, no previous blep, no dry eyes, no malar pad, no infraorbital fat pad, I'll do a little toxin right here where she crinkles. Look way up in the air, mid-pupillary line, right where the preseptal meets the pretarsal orbicularis. Close your eye. She has a little mascara on, and that's a little Elvira look, which is a good thing. Look way up, way, way up, way, way up. Open your eye. That's way up. And again, right in the preseptal pretarsal junction. So if I look at my whole brow rejuvenation, chin down, we have done 5 to 10 units, 5 to 10 units, 10 units, 10 units, so 40, 50, 53, 56, 59, 61 to 65 units at the drop of a hat. Now that's without the extra Botox in her corrugator apparatus. So I did her head. I will do a little in her body to minimize corrugation in the frown area, but I will not go after her tail. Now I'm up to 70 units. So 70, 75 units, very common when someone's in their 50s and 60s for a brow lift. In general, I use a unit for every age they've been on the planet. Baby Botox, millennial 30-year-olds, that's a 30-unit job. 40-year-olds, that's a 40-unit job. 60, that's 60 to 70 units. 75, whoo, that's surgery in a gallon. Okay? Now, mid-face, what can you do with Botox mid-face? My goal is to get that cheek lift up. I don't want the nose plunging. You did a rhinoplasty when you were younger? Yeah, so she had a transcolumellar incision, little rhino when she was a little younger. Big smile. Her tip plunges a little bit when she smiles, so I want the tip to elevate, not Miss Piggy-esque, but a little elevation. And I use about 3 to 5 units right in the DSN, depressor septi nasi. This never feels good, but either does aging without fighting it. And I put 3 to 5 units right there, and that minimizes the tip. It allows the tip to elevate, which accentuates the malar zygomatic buttress for injectables. The other area that will be helpful, I want her lateral lip rolling out. She's too prolabial dominant. She has that sort of pterodactyl lip. I want to get more lateral lip, not central prolabial segment lip. And so I want levator labii superioris to roll the lip out a little bit. That means I want OO, orbicularis oris, to roll in. So I put 1 unit in the lateral 10% of orbicularis oris right there. 1 unit right here, deep down to the hub, and that will minimize the rolling in and optimize the rolling out. So there's 5 units, 6, 7 units. The last little bit for mid-face is allowing zygomaticus major and minor to do this, and DAO not to do that, the pulling down. So I inject DAO. I avoid the basal border of the mandible because I can get DLI. So I come down about 2 centimeters down the LMF, labiomental fold, turn, and inject right into the DAO as it's coming into the modiolus of the commissure. About 3 to 5 units here. Down the LMF, turn right into the DAO, 3 to 5 units there. That allows zygomaticus major to lift and knocks off DAO. Then we're going to do intradermal support as well. So mid-face lifting, DSN, OO, DAO. Depressor septi nasi, orbicularis oris, and depressor angularis oris. 3 to 5, 3 to 5, 10, 11, 12, 15 units. So 75 up top, 15 down below. Almost a bottle of Botox to uncouple all the depressors that bug me. Now the elevators, zygomaticus major and minor, the elevators of the nasal tips, the frontalis, can exert their influence without the tonic depressive effect of the depressors. So think of yourself with your Botox as a freedom fighter. You're emancipating elevators from the tyranny of the depressors all over the face. So find the depressors, make sure they're active, and knock them off. No one looks Botox with no depressors. They look Botox with no elevators. Okay? Now I've left all the elevators intact. She should look perfectly normal. Now we're going to add volume to that formula. Now we're going to add volume, and we're going to use a couple of products. Allergan, 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 Allergan. I like Allergan. They're a good company. Annoying, but good. They give me what I want sometimes, and what I want more expensive than I like other times. Voluma is a great product for volumization and support in areas we don't have to worry about thin skin like the under eye. I've been using this 8 years, been available in the US the last 3 or 4. In international markets, they used to send this as a 5cc syringe from Cornell that was bought by Allergan. And we had to dilute our own with a 3-way stopcock and a bunch of 1cc syringes with lidocaine. So I don't call it diluting. That sounds like you're cheaping the patient out. I add additional lidocaine for comfort. So they already dilute it for you anyway. It's not pure Juvederm Voluma. You get 0.1 of Voluma, 0.9 of Voluma, 0.1 of lidocaine. I'm just adding about another 0.4 of lidocaine for comfort, and it's going to last 1 year, ma'am. So, ma'am, I've added lidocaine for comfort. It's going to last 1 year. I don't say 2. Never does anyway. And that's how you get your product cost with 0.4 added. One syringe goes from $400 to $200. At $200, you can afford to do a 6-syringe Voluma lift. I'll explain that further because I see some blank stares. Either that or you have a lot of Botox going on. So I'm going to hand this back to our customer service-oriented Nadia, who's going to give me the injection strategy, which is no sharp needles. Sharp needles equal the risk of angioembolism, necrosis, and blindness. Not that a microcannula mightn't do that, it's just least likely to, in my opinion. The main reason I use microcannula is fast, less bruising, less pain. Now, if you look, this is what I use, this company, Dermasculpt. They're warehoused in Miami, Florida. It's got a DIN number. They'll ship to you from the internet a box of 25. Each one's about $5, so use 1 per patient. Turn it around, what do you get? Well, I use a 22 2-inch or a 25 2-inch. I use thick products, so I can't use a 27. I can't get Voluma through it. Pops off the syringe off the luer lock. So 22 is my most common product. If I'm just doing under eye alone or lip, I'll use a 25, but I use 22 everywhere. That means we have to have a port creator, because a cannula can't get under the skin. That's about 1 to 2 gauges bigger than the 22. So usually a 21 or 20 to make the hole, and the 22 to get in the hole. And so if you look at what they give you, and you think, I wonder what, if I was going to draw an arterial blood gas, if I wanted to get in an artery with an arterial blood gas, what kind of configuration would you design? Would you design an arterial blood gas needle that looks like that? Probably pretty tough to draw a damn artery on this. So if I'm looking for angioembolism, some things just make sense de facto. No one's going to do a randomized double-blinded trial injecting 1,000 faces with a sharp needle, 1,000 faces without, and let's measure the necrosis rate. No one's going to do that. But, you know, someone's going to stand up in court of law and say, you know, in all probability, you should have used a microcannula. That's how you got necrosis. You should have used a product that easily goes away with an enzyme. Therefore, that eliminates all the non-intradermal particulate injectables like Sculptra, Articol, whatever it's called now, something Bella, used to be Artisense, Artifel, Articol, something Bella. I do it intradermal for acne scars, intradermal corner of the mouth, but never deep sub-Q, because if that particulate of Radius or Articol or Sculptra gets polygalactic acid, gets wedged in a little capillary bed, and you've got impending necrosis, there ain't no going back. There's no reversal agent. That's why I like HA gels. They last about a year. The face changes every year. And I do it every year, and if I get wedged in a capillary bed, I can use hyaluronidase and make it go away. Reversibility, microcannula. Now look at the non-microcannula solution. Let's say you use a sharp angiocath like they give you to inject with, and I said, well, what would go into an artery better? This, that spear, or this blunt microcannula? It doesn't take a rocket science or a good lawyer to figure out what's the best argument. So no one will ever prove it. I'm just using it because it's super fast, painless, less bruising, and it may have the less risk of angioembolism. Okay, so let's do a little buttress on the supraorbital region. And so I put a gauze on each side, one for dabbing and one for parking, my port creator. And I do buttress number 1 first. I go under the tail, watch out for a vein. I create a little bit of a spread there, pull back, park my needle in the gauze so I know where it is at all times. And so park that so you know where it is at all times. And then I take my microcannula, remember the 30-degree angle or whatever angle you use, and we're going to get rid of that. Wipe off the little bit of a heme and find your port, and you're going to go under your port. Now you have to be assertive. I'm going to go right through the skin, orbicularis oculi, right down to the periosteum. Boom. That was the sound effect. Boom. And you can feel it go through the orbicularis oculi and bouncing off the periosteum, pull back, slide right along the supraorbital buttress. Now why did that not hurt at all? Thank God for dilute lidocaine. She's numb. I did that little mesocaine in a supraorbital buttress. Now I take my Voluma, reconstituted for comfort. This is 0.5 of Lido and 0.5 of Voluma. How did I do that? Two-way stopcock. Inject, take your full Voluma, inject 0.6 of that into a syringe and add 0.4 of pure Lido. Your 0.6 had 0.1 and 0.5. Now you 0.5 and 0.5. Half Lido, half Voluma. Now, will this make the product last less, open it up to more degradation? Yeah, doesn't last 2 years, but lasts 1 year for sure, because I've been doing it for 10. So this is a reconstituted comfort, ma'am, so it's more comfortable. It's going to last 1 year. I want to see you once every year for volume correction. This syringe now is not 400, it's 200. 6 times 200 is 1,200. That's your disposable, which makes it affordable for you and the patient for a 1-year volume correction. Okay? Voluma reconstituted for comfort. And now we just inject. Now the injection technique I use is deep supraperiosteal, what I call needling. I advance, inject on the way back. Zoom in a bit more. Just so you don't see my super clean fingernails. A bit more. That, excellent. And I inject, put that in the center of the screen. A little bit more, beautiful. Advance, inject on the way back. Advance, inject on the way back. Little toothpicks all the way across. Now most lift I want is right here. I stay above the eyebrow hair. And I put about 2/3 of my 0.5 right there to lift the tail of the brow. And I'll show you what I mean by toothpicking. Advance, low volume, low pressure on the way back. Advance, toothpick, advance, toothpick. I create little homes for each little toothpick so it doesn't distort, doesn't get compressed, and it's close to immunologic response so you don't get nodules. And now when I'm done with that, the next 0.5, I'm going to put in the temporal hollow. I simply turn my microcannula. I pop under the temporoparietal fascia. That stings a little bit, because she's not under local there. I inject a tiny little bit right there, and I massage it in at the depth of that concavity. She doesn't need a lot. Often I use up to 0.3, 0.4, 0.5. And there's your supraorbital buttress, supraorbital temporal hollow. And just doing that little bit in her supraorbital bridge lifts the tail of the brow up a little bit. Put a little pressure on the heme, and we'll look at that in a second. So that's the supraorbital buttress. Now I'm going to do, this is why I like the 2-inch. I'm going to do the infraorbital, orbital malar, and zygomatic all with one port. I can get everything with a 2-inch, 25 or 2-inch 22. Okay, keep your eyes closed so you don't get a corneal abrasion. Okay, so I'm going to hand this off. We're going to switch our product. The under eye Voluma is too big. You get a lot of hydrophilia. That's the problem with the Juvie products. They're kind of hydrophilic. So I used to use a lot of Restylane there, and you can use that. Oh, Bolatero there. That's pretty good. I also use Volbella. Volbella is a good product for there. I think it's now FDA cleared here in the United States. Back to you. And so you can keep all your points with one company, Allergan, 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 Allergan. So we're going to take this needle, 30-degree angle. I come down to the base of the malar eminence. I can go up, across, and side to side through one port. 30-degree angle. Why 30 degrees? I just remember my angle, so I'm not bouncing off the dermis. Use the same angle each time, 20, 30, 35, 40. Otherwise, you look like you don't know what you're doing. You can't get under the skin because you're hitting the dermis. You got the wrong angle for your microcannula. The angle of your port needs to be the same angle as your cannula. So we take that, park it, and we're going to use our Volbella. I use about half a cc of Volbella, and it's going to be reconstituted for comfort if you want as well. And I'm going to make this a 30-degree angle. We're going to go right through the malar fat pad. I'm down on the periosteum of the malar eminence. I slide right up the orbital malar groove to the orbital rim. I'm at the orbital rim. I go right under orbicularis oculi. I'm literally right up in the medial canthus now, right there. I can feel my microcannula. Chin down. Chin, no, your whole head down. There we go, so we can see. Now, I'm going to inject right along that tear trough under orbicularis oculi. Little toothpick, very small amounts here. I'm filling up that tear trough. Now I'm going to move right across the lower lid and back again to plump up orbicularis oculi and the skin, and any fat pad gets camouflaged. So I move across the infraorbital buttress, retrograde toothpicking, antegrade advancement, inject on the way back. Antegrade, inject on the way back. Antegrade, little toothpicks all the way across. Now when I get to this little area, I want to fill in that little hollow that'll be magnified by my malar zygomatic arch. I inject on the way back. Okay, now let me show you what I mean by a toothpick. Watch this. As I pull back, there's a toothpick. Antegrade advancement, retrograde low pressure, small volume toothpick. Little toothpick. And thousands of these little toothpicks give structure. They're all stabilized in their own little home, because as you advance, it pushes the tissue out of the way, and as you come back, it closes on it, stabilizes it, doesn't move. You also have a very close blood supply to each of these little toothpicks, which means it might break down faster. I don't care, it's gonna last a year. What I don't want is a giant glob, a blob, that your immune system can't get at. It frustrates the immune system, and you get a biofilm reaction or allergic sensitivity nodule 7-8 months later. So the 3 giant blob injections, I don't believe in. I do these little toothpicks. I've never had a nodular reaction, but I don't inject giant blobs. Giant blobs alert the immune system to something foreign. It might alert something foreign, but it can get at it. Doesn't get frustrated. You don't get immunologic, non-infective, nodular reactions. Okay, so that's my theory. You might talk to 10 other specialists who disagree, and everyone's got a different opinion, it's just that mine's right. So now we're going to abandon our valbella. We're going to come down the orbital malar groove with voluma, and then whoosh, right at the zygomatic arch. 1 port, 2 zones. Infraorbital buttress, and if you look at her lower lid, hollow's been corrected, lateral canthal indentation corrected. Now I can build up her malar zygomatic arch and not accentuate the hollowing. Okay, we're back to voluma, reconstituted for comfort. And we're going to go through our little port here, and we're going to continue from the orbital rim, where I stopped off with valbella, move down the orbital malar groove with a little bit of toothpicking. Now, you don't want to spend a lot of time here in someone who has a full mid-face, because she's going to look like filler face, but you need a little bit there, a little bit right there. Then I turn, go right up her malar zygomatic arch, lift up the soft tissue, zoom right under the soft tissue, above the zygomaticus major and minor, right up to the zygomatic process of the temporal bone, and inject on the way back, little toothpicks. Build up that zygomatic arch. And again, she's nicely anesthetized, but this adds a little V1, V2 in zygomatic and temporal nerve anesthesia, because you have lidocaine in there, so it also adds the anesthesia, so you can do lasering last. By the time you get to the lasering, the Botox has left the dermis, so you don't have to worry about it. So I often put 1 to 1.5 cc's in the average zygomatic arch, half a cc under the eye, half a cc above the brow of reconstituted product. Okay, let's go back to voluma, a little half cc zygomatic arch. And we've done our third buttress. First one's supraorbital temporal, second is infraorbital. This is the third buttress, zygomaticus, malar zygomaticus. And we build that up nicely. I like that sweep. The last buttress of the 4 is along the mandibular border. This is going to help with the jawline lift. Let's look at the lower border. And I want to pre and post-treat that little dip of the jowl. I want to pre-treat and post-treat, give the illusion of this. Now, a lot of people put in the pre-jowl sulcus, but it makes women look heavier. You have to compensate with the mandibular border to get that nice, strong jawline and not a heavy jowly look. So a little bit on the mandibular border through the pagonian, and she's nicely anesthetized, so we can do this very comfortably. We're going to take our voluma, reconstitute for comfort. We're going to build up that little bit of a jawline. I'm going to go through her pagonian here. I'm going to get down on that mandibular border. So I go under the DAO, DLI. Remember your angle. So I go under the muscle, DLI, DAO, and I build up the mandibular border. I feel where the border is, and I put a little bit of product right along that mandibular border to give the illusion of no jowl. I lower this to match this, it hides the jowl. Kind of an optical illusion, but a half cc is all you need. And then I turn. When I've done that, I go right up to the commissure, lift it where I want to see it, and do some deep support along her labiomental fold. That never feels good. It's all part of the looking better pain. Okay? Now I'm not done. I still have to do the back of the jawline, which everybody forgets to do. That little dip at the jawline to strengthen it. You don't want to create like a masculine jawline, but you want to create a nice jawline that doesn't look droopy. So I go right through the jowl. And we're going to go back to the mandibular border, and I would do this while the freezing of the neck was taking effect. I would be doing this. And so we'd be doing this while we're waiting to do smart lipo. And I do the retromandibular angle. I'm right at the angle. I'm going under the masseter. If she has a giant masseter and a square jaw, what a great time to use 45 units of Botox in the masseter to make her face more oval. And again, build up the jawline so there's no dip there, but a half a cc. Okay? So now when we look at her now rejuvenated structure, we can look at that hemiface. Show me the whole face, just relax, I got you. You can do the supraorbital brow, zygomatic sweep on the jawline. I'm liking that compared to the other side that looks deflated. So now we have to do the same thing on the contralateral side. I'm going to make you my assistant, Take your left hand, the only time you're allowed to bring your hand up, and hold a little pressure right there, flat-handed, like so. Beautiful. Now, while she's doing that, I'll do exactly the same on the contralateral side, but we'll go a little bit faster, more real time, okay? And so you know your anatomy. You want to apply a 30-degree angle, rotate, and now you can actually park your needle at the next location. And now you're going to take your microcannula, 30-degree angle, we're going to go under the orbicularis oculi, advance, little toothpicks on the way back, build up that lateral half of the brow, advance and jet, voluma reconstituted for comfort, advance and jet, advance and jet, advance and jet, advance and jet, and we're going to turn and get right into that temporal hollow, and that's going to sting a little bit because I didn't do any freezing there. A little bit of product, massage it in, and then you've done your supraorbital buttress on this side. And we're ready to go here, so we're going to remove that, go to the next buttress, park the next buttress, and take our microcannula, and we're going to go right up under the orbital rim, under orbicularis oculi, right up to the medial canthus. I'm going to remove my voluma reconstituted for comfort, go to Volbella, perhaps reconstituted for comfort, and inject on the way back, little toothpicks right down the tear trough till I get to the orbital rim. I'm way up here, right down the tear trough, about 0.3 to 0.5 in the average tear trough. Once I get to the orbital rim, I turn and I advance and jet on the way back, advance and jet on the way back, I'm laying toothpicks all along the infraorbital buttress, under your orbital rim, right up to tarsal plate. I'm feeling with my fingers so I know exactly where I am. I get right to the lateral canthus, lay down a little product, and I go back again. Now I'm going to show you with a zoomed in view exactly what's going on here, because this is the toughest buttress of all. Get rid of her mascara here. Now look way up, way up. As I hit her tarsal plate, I lay down a toothpick, and then another one, and then another one, and then another one, and it supports the lower lid. It plumps out the skin. It hides the fat pad. That's what I mean by toothpicking across the lower lid. Close your eye. You have to know where you're at and what you're doing, of course, but it works nicely. Now I'm going to switch, come down the orbital malar groove, up the zygomatic, malar zygomatic arch. So this is buttress number 2, buttress number 3. I come down buttress number 3, down this orbital malar groove. I'll build up the malar eminence. Some patients need a lot right here. She doesn't, or she'll look like filler face. Again, little vertical toothpicks, horizontal toothpicks, turn and go right up the malar zygomatic arch and inject on the way back. Build up that nice zygomatic arch. Excellent, beautiful, looking great. And now swap out another half cc and build up that zygomatic arch. Now, once we've got the zygomatic arch and malar eminence, infraorbital buttress, supraorbital, again, the last is the mandibular border. And we want to make a nice mandibular border for her. And we're going to swap out for voluma, reconstituted for comfort. I'm going to take this, put the next one in the jowl, and build up that pre-jowl sulcus and the labiomental fold. 30-degree angle, know where you're going. You're going to go under your DLI DAO and inject on the way back little toothpicks of gel. Build up that mandibular border to hide the jowl, the subtle jowl that she has. Build that up nicely, not too much, you don't want to look jowly. And then go lift up the commissure, go right past it, little support in the commissure and down the labiomental fold. Sometimes they're very hollow here, and I'll fill that in as well. But that whole buttress now, we've got the jawline evened out. We do the retromandibular border, park your port creator, and we're going to do the retromandibular border right here. Go right through masseter, and again, you can put Botox in the masseter to soften this area, create more oval look. And we're right down to the mandibular border, dab the heme, and build that up. And just a tiny bit more. So once I've got my 4 buttresses, supraorbital, infraorbital, malar zygomatic, and mandibular, on both sides I've got a nice cake baked, and that cake should be oval, not jowly or square. We tend to get square as we get a little older. And so we've got a little square that's gone to an oval. Back to you. And now switch hands, young lady. You're going to be my assistant on the other side, okay? Bring that up, little pressure. So now we have to have a strategy. We're going to look at symmetry, look at balance. We'll touch up the cheekbones if we have to make them symmetrical. But I want to add a little lip, sometimes a little nose, okay? A little lip for her will be important. And you would look at maybe the zygomatic arch, see if you have to, at the nasolabial folds. Sometimes nasolabial folds need to be injected, but not often. Come on off just for a sec, chin back. So I look at the balance and proportion I need a tiny bit right here. Hold pressure along your jawline. A little bit right here, so I'm going to use a little bit of Voluma just in the hypomalar region right here to be more balanced. What side of your face do you sleep on most?
On my back, actually.
You're a back sleeper. Well, that's exactly what I recommend. Perfect. Now that'll build that up so it's more symmetrical. Come off and have a little pressure right here. So now what about the lip? If we look at the lip, I want to get the lateral lip segments and certainly the lower. And you can get the NLF and the lip through the same port apparatus. So turn this way. I want to be able to come down the nasolabial fold. I want to get to the lip if I have to, both ways through the same port. So I'm going to park this, and now I'm going to do a little nasolabial fold, pretend. She doesn't need it, but I'll show you how you would do it. You go through your port, down at the base of NLF, find your port, make sure there's some heme. If you don't get any blood out your port, check the carotid, just make sure your patient's still alive. And that's working out well for her so far. And again, there's her port, 30-degree angle in that port. I'm making it look very easy, of course, probably because I made it this way. And now I go up my nasolabial fold, and I can do subcutaneous. I don't go deep here. And this is a common area of reported necrosis, a lot of angular and facial artery here, nasolabial artery, so just subdermal if you want to do the nasolabial fold. I'm not a big nasolabial fold injector. You make people look simian. Like Rise of the Planet Ape 2. Most people don't want to look like Caesar. They want to look like James Franco, and he has smile lines. And so generally the lateral lip, this is what I do. It's a bit unusual. We're told to inject here. I have no idea why, at the wet-dry junction. I like to get vertical height, so I inject way back here and create vertical height. So there's vertical height right down to the commissure. That means I'm going to go into the lip. I'm going to pierce through orbicularis oris right there, and I stay ahead or in front of the mucosa and below orbicularis oris along the wet mucosa. I advance, inject on the way back. No bruising, no scalloping. I never pierce the lip. And this is it's a bit tricky. You got to practice it a bit, but you'll never use another piercing technique again because you get that lip open right to the corner with zero bruising and zero scalloping. If you're getting bumps, you're in the muscle or the mucosa. If you're getting bruises, you're getting vessels. Okay, back to you. Come on off now, hands down. And let's do the other lateral lip segment. And we can do the lower lip too through the same approach. And so we're going to create a little nasolabial fold, commissural stab. I can go up, I can go sideways, I can get in the lip or up the nasolabial fold. We're going to do the same thing. We can pretend we're doing nasolabial fold. Retrograde injections on the way back. She doesn't need it. Now you can see this side a little easier. I'm going to open your mouth, rotate the lip out. I'm going to pop through orbicularis oris right there. Now I'm under orbicularis oris but above the mucosa. I simply slide in that loose areolar zone, open your mouth, right up the lip and inject on the way back in that wet mucosa. And it rotates that wet mucosa out, gives her more vertical height to her lip, and there's going to be zero bruising, zero scalloping with this technique. Now I can also turn the head, grab the lower lip, turn, and I can get right into the lower lip as well through the same approach. Through orbicularis oris, I can get right into the lower lip quite easily and get right out to the central prolabial segment, inject on the way back so she gets a little more balance between her upper and her lower, and come right back to the commissure to support the corner of the mouth. And same on the other side. We can go get up into that lower lip segment, rotate, grab the lower lip, turn it out, pop through orbicularis oris, slide in that loose areolar plane, right to the central segment, and inject on the way back. She has a little more upper-lower lip balance from her profile. So now her lips look a little more balanced. Okay, now we're not done yet. I've done all the deep sub-Q supraparietal injections, not one single injection in the dermis, not one. Now we're going intradermal. I want to support her lip a little bit, and I want to create some white rolls for her. So let's go intradermal. Now if you're going to do laser work, do this after the laser work, because you're going to make the product go away. I won't laser commissure. Yeah, intradermal. Perfect. And get me a 30 gauge 1 inch. So I'm going to use a little Volbella in the corner. Actually, put that in 30 gauge 1 inch. Give me a Voluma on the 27. So now I'm going to go intradermal. Why? I want the corner of her mouth a little more horizontal, especially on the left side. Okay? So I'm going to pull that lip where I want to see it go. I'm going to take my product. I want to create an upward turn commissure. It's got to look at least neutral or up, or because it is going to fall in the first day or two after your injection. So Voluma on a Sharpie. Give me a piece. Okay, and then the Volbella on the 1-inch 30 gauge. Awesome. 27 gauge sharp needle, much more likely to get intraarterial. So I'm going to use this for intradermal injections, no risk here. I make a little C, and I inject right around the corner and inject on the way back, inject on the way back. Really elevate that commissure. And then if that's the tabletop, I put little legs on that tabletop to support it. And now we get a nice upturned commissure. I can use the same on the other side, so it should look like Heath Ledger Dark Knight 2. When you are done, a little upturned corner, it comes down by the next day. But if it looks horizontal now, it's going to drop the next day when the local comes out. Lift where you want it to go. A little pressure right here, young lady. Uh-huh. There we go, beautiful. And I lift the commissure where I want it to be. I take my 45-degree angle, I go intradermal. I can see the gray or the white of the needle. Inject on the way back, creating a little commissure support, pushing the commissure up, supporting it. And then, once I've got it supported, I make little vertical legs, pushing that tabletop up, all intradermal. So she'll feel a little nubbin there. She should feel a little nubbin come off, or you haven't done enough. Lift that up again a little bit more. Hands down to your Botox bottle of reassurance. There we go. Excellent. And push that up. Now, if we look at her sitting, that's nice commissures. We fixed a downgoing mouth. Botox hasn't even kicked in yet. Now, you might accentuate, even though it might be a little overdone, the white roll, especially in a younger lip. And I use Volbella on a 30-gauge 1-inch. I simply zoom in on the lip here. I simply go right intradermal. I advance right up the white roll to the Cupid's bow and inject on the way back. I'm intradermal or immediately subdermal and create a little bit of a white roll support. Same on the other side. This helps with bleed lines and gives a nice natural white roll look to things. And you might accentuate the filtral columns and the filtral columns on both sides. And she has a little traumatic scar on her upper lip from something. What was that from? A toboggan accident. The dreaded toboggan accident, yes. From a Griswold family Christmas. Relax. Okay, and then a little bit in the lower lip white roll. And again, this is a very sort of standard architectural reconstruction of an upper lip. Now I'm going to get her to be my assistant. I want you to open, close, close. Bring both hands up and hold pressure, one on one side of the lip, one on the other. I'm going to clean off with a little alcohol wipe. We'll look at her volume proportion, see if I need to add anything, and then right over top with CO2 in the areas that need it. She's already numb. Now, her Botox has already left the derma, so even if I were to inject over Botox areas, it's already left the derma, so I don't have to worry about that. Almost all my areas of Voluma and Volbella and Volura, if we used it, are deep sub-Q or supraperiosteal. The CO2 is not going to affect at all. I just need to be careful on her white roll so I don't degenerate the product. You just inject it at the dermal level. Okay, another alcohol wipe if you have one. Awesome. And I'm wiping off all my eyebrow liner marks. So make sure you use a road map, then wipe it off. Come on off here. Back to your balls of reassurance. If we take a look at our young lady now, she actually looks pretty good. She's got about 8 syringes of product, about 100 units of Botox, and she's looking actually not bad. Brows are up just from the filler. Zygomatic arch looks good. Her jawline, chin up looks nice. Now I just need to add that laser, the laser part. Okay, so let's give her goggles. Let's bring in Mr. CO2, and we'll segmentally laser some areas, acne scars, upper lip lines, upper lip toboggan accident scar. Just clean up her skin. Remember that facelift scar? Come back in here. Let's show a little more aggressive laser work here. We're going to now go into energy. Now we're going to jack it up because it's thick, glabrous skin. A lot of wrinkles. Got to do some work here. The neck's very delicate. None of this 8-watt nonsense. We're going up right up to 30, high as it goes. Now this is your 7 to 10 day, maybe 2 day recovery. I want longer pulse duration, not 1,200 microseconds. I'm going to give me 1,500 microseconds, more non-ablative thermal coagulation. And I still want to go pretty fast. Now we're going to make the ablation. Remember it was 15 millijoules, and now we're 45 millijoules per spot. Now we want to make the distance closer together, maybe down around 350 or so. So the ablations are closer to 19 to 20% coverage. And we're going to add stacking on the upper lip, not on the cheek. I'll show you stacking, so we drill right down through the skin. Same in the lower lid. I like all that. We hit yep, and now we're upwards of 45 millijoules per spot. That's more aggressive setting for sure. Want to calibrate and then hit go. So now we're going to give her 0 wrinkles, reduce acne scars, improve pores, and she's going to look smoother in addition to volume shaped and uncoupled. Hit the ready button. Okay, we've got our eyes protected. We've got our smoke evacuator for the buffalo filter. We're ready to go. Now we're going to treat our acne scars over the cheeks. I'm going to go right where the central scars are. And we are doing the normal, and she's feeling absolutely no pain. This would not be tolerable. I usually use the autofill, but because I did your mesocaine, light tattoo removal, this would be agonizing. She'd jump off the table screaming in agony. She'd report me to the federal officials in Canada, and I'd be tried in The Hague for human rights violations if I had not done mesocaine. Not that Brussels is bad, but I don't want to go there. Excellent, you're doing fantastic, and we're treating her acne scars. Now that's pretty aggressive. I got to blend it in a bit. I'll show you what I do. Excellent. Getting some nice acne scar results here. Beautiful, and her T-zone pores. That gets painful. Now, take a look at this white scar over there, the facelift junction. I take my blue button, go from square to triangle to rectangle, and I go right along the facelift scar. Right along the facelift scar. She doesn't like it, but she doesn't like her scar either, so she'll put up with it. And I can also do the one around the ear, which is often a little bit visible, and under the earlobe. So don't leave your scars alone. Go after them and improve them. Now that was not frozen. She didn't like me. Turn this way. Now we're going to go back from our rectangle to our square simply by using our handpiece to control it. And we'll fill in these acne. Let me switch hands here. Back to you. And I put a little bit of stretch on the skin, and we're going to treat the acne scars here. And so she's got old acne scars. They're looking better, but we're going to make them better still. Overlapping about 20%. Little T-zone pore action here. Nice aggressive rejuvenation of this area. And then we're going to do her upper lip lines and upper lip scar. So integrated energy-based treatment for neck tightening with Smart Lipo, CO2 on top, volumization, toxin. The goal is to lift in shape, not to fill in one area. And that was where she wasn't frozen, just to show you that freezing really works. Now I'm going to go to the rectangle, relax. We're going to minimize that visible scar you have there. Zoom right in on that, not acceptable. We're going to make it awesome. And there we have our rectangle. Now let's make this much less noticeable. Not fun. It's tender in the ear. Nobody wants their ear resurfaced. I'm just apologizing in advance of all the people out there that are looking at you going, oh my God, who would do that? Well, anyone who wants to look their best, that's who. Okay, now, we still need some aggressive upper lip work. She is numb there, and so we're going to do a little bit of lip resurfacing, staying above the white roll so I don't damage my filler. And this would be, again, unacceptable if we hadn't done some degree of freezing. It's turn this way. It's almost unacceptable now. You're doing great. And then that one little lip scar that you hate right here. 1, 2, 3. And perfect. Love it. Now, I want to blend all that in. She also has a little bit of a frown line right here. The Botox has left. I want to sort of treat that a little bit. And then I want to blend the areas. I want to blend the areas in that we have treated. So come back to the machine. Now it's important to blend, or you're going to have demarcation. This is very aggressive. So I go back into my settings. I go to a pitch distance that is farther apart. Okay, down to 10% from 19%. I go back into my laser settings. I go from 30 down to about 15. And I go from 1,500 down to about 1,000. And now I can blend everything in so it looks even. There's no sharp edge where we did aggressive laser, light laser. So always remember to blend your work in to make it look natural. Okay, so back to our square. And let's blend this all in nicely. Much less energy. And a little blending energy here so there's no demarcation. Okay, so I'm taking those sharp edges and blending them in. She's quite numb in her under eye. Also good time to treat her righted, so you can take the goggle, don't move, lift them up a bit. I can pull down with the actual handpiece and treat the lower lids for some crinkle wrinkle reduction while I'm here. Very straightforward. Blend in laterally. And we've minimized any demarcation for her. I usually go right down to the mandibular border with very light settings. And she's blended in very nicely here. Now we go to the upper lip, blend that in so it doesn't look too sharp. And contralateral side. Again, it's got to be comfortable. It's never painless, but it's rendered doable with the art of mesocaine without any real block at all. This can be easily doable in the hands of any physician who may not be doing a lot of facial blocks as part of their normal medical practice. And again, blend down right down to the mandibular border. And this will add that little bit of improvement in all aspects of her facial appearance. And then we want to blend in the glabella ever so slightly because that was quite strong. And we blend in on either side so there's no demarcation point. And she's reasonably comfortable. Now, the same thing holds true for the neck as the face. Once you're done here, you've done your toxin, done your filler, done your CO2, and we started, about 35, 40 minutes ago, and we went a little bit slower than normal. In all, this whole thing, neck, face, generally, if it's the patient's already prepped and in this, I can do this in about an hour. So let's say it takes you an hour and a half, 2 hours when you're first starting out. Let's talk about pricing, okay? So let's take a little bit of a damp gauze, and we're gonna wipe off the ablation, and now we would go to a polysporin or PRP on top and injecting underneath and polysporin after. She's gonna have a little wrap. I'll show you the wrap that she's going to wear. And we're wiping off the ablation. Zoom in so we can see what we're doing here. You can see the ablation is a little yellower here in the center where it's much deeper and whiter on the side. That shows you we're quite deep for her texture improvements. She's gonna have an awesome result here. So here is CO2, 8 syringes and 100 units. Zoom out, let's see the whole face. She looks actually not so bad for, looking not so great. She looks bad in a good way. Bad in an anticipatory good way. So let's put a little bit of poly on there. You can put that on. And then we need to put her in a wrap. So she's gonna wear a wrap for the next 7 days as much as possible to get that skin to stick down to her neck muscle. I use a soft silicone-backed wrap, not a formal facelift garment, so it's easy to wear. And she can wear a big pair of Elton John sunglasses and a hoodie and go out and be reasonably acceptable in any small community where people have vision issues. So you're gonna look awesome there. You're going back to St. John's? Oh, you're gonna stick out like a sore thumb. Doctor, who should we use? Dr. Gillett. Okay, use her name. His name.
Perfect. Okay.
So I just gave her the name of a dermatologist I don't like. I'll wander around Newfoundland telling everyone that Dr. So-and-so treated your precancers. The next time you're back and you look awesome, I've seen Dr. Mulholland. Yeah, he did all this amazing work with no cut. Okay, now, stretchy foam, silicone backed, very comfortable. Chin up. And we come right to her crown, the vertex for you in medicine. Took your head off the bed. And you want a fair amount of pressure. It sticks to itself, no clips needed. And that's it. She's gonna wear that, keep her skin moist for the next 7 to 10 days, and no rubbing for 3 hours while the Botox is setting. And she's already sleeping on her back, but get them in an airplane pillow sleeping on her back. So, before I head out of here, how much would you charge for that? Well, I always charge whatever I can. That's my price point. Thank you for videotaping. You did awesome. Thank you. So, but there's a practical way to price things. Let's start from how much it costs you and build up. So what did that cost me? Let's call it 10 syringes, but that's a lot. You'll probably use 4, 5, or 6. Now, each syringe from Allergan, they want to charge you $400, but you're going to reconstitute for comfort, and you're going to get it for $200 a syringe. At $200 per syringe, still a syringe, just dilute, reconstituted for comfort, it's going to cost you not $400 but $200. So 6 syringes cost you $1,200. So if you just did the volume lift, you could charge $19.99 or $22.99 all day long for a year of lift. $1,000 for half an hour work. Better than Obamacare. Number 2, Botox. I put a whole bottle in there, 100 units. That's about $600. So you should charge at least $601.